Welcome to Phacilitate's digital platform. We are here in Miami at our annual event, and I have Dr. Lee Schwartzberg, Executive Director for the West Cancer Center, joining us. Thank you very much, Lee, for having a moment to speak to us today.
Thank you, Nick.
So what I was really curious was, we have a lot of different interesting developers. Novartis produced their CAR-T results here at this meeting. But when we're talking about delivering these immunotherapies to patients, what do we need to think about aside from the science? I know you've been doing a lot of work in thinking about that infrastructure.
Right. As a clinician, this has never been more exciting in terms of therapies for cancer patients. The IO field is incredible. We're really just at the beginning of it, but we see challenges. We see challenges in terms of access for patients. We see challenges in terms of how we're going to integrate these therapies, particular therapies like cellular therapies. Will they be given in a broad way, or will they be given at individual centers with expertise? Right now, with our checkpoint inhibitors that are available, it turns out they're fairly easy to deliver. So actually, in terms of getting the drugs and giving them to patients, that's not a big issue. We are struggling with the side effects of these drugs. They're very different than traditional chemotherapy drugs. The awareness of the understanding, the late side effects of, for these patients, and particularly, not for the oncologists, interestingly, but for the other specialties that now need to be aware of the toxicities of the checkpoint inhibitors, for example, and the effects on any organ on this. And we'll see that, I think, with all immuno-oncology, because it's really stimulating the immune system and can target any part of the body. So it's very different than traditional chemotherapy types of toxicities.
And what do you think then developers can do more to educate the people that are going to be delivering these treatments? Can they do more?
Yeah, I think it's a great question. Already the manufacturers are thinking about this, and they've had to, as we learn more about real-world evidence and how these drugs work in patient populations that aren't necessarily the same as were in the clinical trials, which are very carefully screened, as you know. So yes, educational efforts are underway, not only with the providers, the specific oncologists who are giving these drugs, but also other subspecialties. And I think manufacturers, interestingly, could go to other specialty meetings like cardiology and endocrinology and dermatology and start to talk about it, because these are the providers that will be seeing these patients in many cases, and we need for rapid intervention. The other thing is patient education. And this has always been important, but it's never been more important than with immuno-oncology. So I think we are seeing some novel approaches to patient education, access to patients, interactions with patients using technology, for example, and I think those will continue in the future.
And so in terms of delivering combinations, there's many presentations we've had about different combinations and the exciting science around it to get better responders. But actually delivering combinations then to the clinic, what do we have to be thinking about? And how possible is it going to be in the short term or even in the long term?
So we still don't know yet either the efficacy or the toxicity of combinations, but let's assume that the efficacy is greater, and there's every reason to be optimistic about that. I think we'll see different toxicities, and I think we're going to have to focus. It won't be, again, focusing so much, particularly for infusional therapies, on the toxicity of delivering it, which sometimes with chemo it is, but what happens downstream. So with combination therapies, we would expect more extreme perturbations of the immune system, which could occur at different times. So I think we're going to have to follow these patients long term, particularly now that we have patients that live long term with their disease in remission. So it's a whole different paradigm, and combinations, in my opinion, will actually expand that and will make it a bit more challenging.
Now, I don't know how much you can speak on this, but the burning question about payment and reimbursement, even comes up in our investment summits, because they want to see what the return is and obviously fuel this innovation. What is that environment looking like or developing like, about models, and particularly even with this Trump administration? Can you even touch on how you expect it will change? I know we can't answer specifics, but...
Right, so we're at a period of tremendous change. No one knows what's going to happen. One thing I do think will persist, regardless of the new administration, is this movement from volume-based reimbursement to value-based reimbursement. So we're clearly moving to that direction, and I think that horse is out of the barn and not coming back. So how do we create value here? And that's a big challenge as it relates to immuno-oncology, particularly combinations, which could cost $250,000 per patient per year. That breaks the bank. So we really need novel strategies here about approaching this. And in my own opinion, I think if everyone gives a little, the payer, the manufacturer, the provider, and the patient, and we all come to a way of risk assignment to all, I think that's the global way to do that. Now, how do we get there? That's a big challenge, and we'll be spending the next several years figuring that out.
Thank you very much, and perhaps we can catch up on our next event, Lee.
Wonderful. Thank you so much, Nick.
Thank you.